All for today's webinar on new paradigms in the lung cancer management. With immense pleasure, I would like to invite Dr. Sanyu D'Souza, who is consultant medical oncologist, KMC Hospital, Mangalore, for the welcome and introductory note and to take the proceeding further and to set the ball rolling. Over to you, sir.
First of all, I would like to thank AstraZeneca for planning this webinar. So, management of lung cancer has evolved from treatment based on only histopathology to incorporating the information which we get based on the molecular tests of the tumor tissue. So what initially began as only EGFR testing somewhere in 2004, 2005, and then subsequently ALK testing, ROS testing, etc. And now we are having host of other biomarkers. And these biomarkers have been utilized not only in stage 4 cancer, but also in early stage lung cancer. So based on this, we have 3 talks this evening. So first talk I think is by Dr. Vijit based on molecular testing in lung cancer. Second talk is based on EGFR mutated resected early lung cancer. What are the treatment options after that? And then the third talk is by Dr. Karthik, I suppose, based on this osimertinib data, real world data. So I would like to invite Dr. Vijit for his talk on molecular markers in lung cancer. Over to you, Vijit.
Thanks, Sanyu. I'll just share my screen. Is my screen visible?
No.
Just a second. How about now?
Yeah, visible.
Yeah, thank you. So thank you so much, Dr. Sanya, for that kind introduction. And I would like to thank AstraZeneca for this opportunity. So this is one topic which I think all of us in this audience know. And I think I'm sure we are going to have a lot of interesting opinions on the panel discussion as well. So we all know now that we cannot get away without doing molecular studies for lung cancer. And all the GloboCan data, lung cancer is right there on top. Though the Indian data shows that the oral cavity cancer has come up by a large way in the recent GloboCan compared to the 2000 GloboCan. So overall, it's a very high, it causes very high mortality in both males and females. And males to female ratio is slightly skewed because of higher incidence of smoking among males in Indian population, and also incidence of non-small cell lung cancer is much more when compared to the small cell lung cancer. So as we can see, it's very important now to know what is the histology of malignancy we are dealing with, whether it is squamous or adenocarcinoma. So basically, in all the guidelines, it is non-small cell lung cancer. So they're all taken in a basket. But when we are seeing adenocarcinoma, we automatically check for all mutations. Conventionally, we have been always testing for EGFR, ALK, and ROS. And now, even in squamous histology, we are asking more and more EGFR mutation, as we have discussed multiple times in a lot of webinars, that we are seeing a lot of EGFR mutation in the squamous cell carcinoma histology as well. So in addition to EGFR in the squamous cell histology, we are also, there's a lot of data coming where they are finding PIK3 kinase mutation. So that can be targeted with the mTOR inhibitor. Also, more and more EGFR inhibitors also, there are data in other malignancies. So maybe in future, we will be testing for a lot more molecules which we did not have thought of testing in 2021-22. So the evolution of lung cancer has happened from the diagnostic point of view, where it was just enough to know whether it's adenocarcinoma or squamous cell carcinoma, because we would decide what chemotherapy to give. So for adeno, we would give pemetrexed-based platinum doublet, and for squamous was gem carbo or gem platinum plus or paclitaxel platinum. So now we have refined that. So whenever we are seeing adeno or squamous, we are not happy. We need much more. So basic minimum, we are asking for EGFR AL cross. And now in the last few years, additional markers have come in like MET, RAS, KRAS, BRAF, HER2, RET. So these are the newer markers which we are supposed to do for every patient with probably adenocarcinoma on the histology. So by and large, EGFR forms a chunk of the mutation, and as you can see here, we used to send it to some of the labs where they would test for T790M mutation upfront as well. So initially we used to be quite confused as to why we are testing it, where our understanding was someone on EGFR inhibitor develops a T790M mutation as a resistant, part of resistance. So, but now we are seeing some patients have T790M mutation upfront as well. So it makes sense to test for that when we are testing for EGFR mutation. So EGFR AL cross, these are the basic markers which we do, and in my practice I do it. I mean, I have right now confined only these 3 markers because most of the patients can get it done at minimal or nominal cost. And of course, in someone who can afford, we are also getting the PDL1 expression done. So and getting the tumor proportion score or combined proportion score, and based on the percentage of expression, we decide whether to give monotherapy with IO or a combination with chemotherapy, depending on what is the lab report. And as per this flow chart, we decide whether to give IO only or IO with combination. By and large, these are the 4 markers I think we are all doing. I mean, the 5th marker, T790M, comes as a default in some labs, but most of the labs do have EGFR AL cross as standard and PDL1 as add-on. So what is the methodology by which we are supposed to test for these mutations? So EGFR, actually, it is supposed to be a PCR based, ALK ROS by FISH, and PDL1 by IHC method. So from empirical therapy, where we had just which chemotherapy to offer the patient, now we are going slowly towards molecular diagnosis, and also most of our decisions are based on these molecular studies. So also now NGS is being performed in most of the labs, and if patients can afford, I think most of us are opting for NGS because we want to test for all the possible mutations upfront. And it is a confusing scenario when you get 2 or 3 mutations in the same patient. So basically, these are the exon mutations which we are looking at: exon 18, 19, 20, 21. So exon 19 deletion and exon 21 L858 are the most common activating mutations, are the most common of the EGFR sensitizing mutations. And also what sample to test. So FNAC is not enough. So wherever possible, for example, if the patient comes with a deep-seated primary lung lesion which cannot be biopsied, if patient has a pleural effusion which tests positive, I think cell blocks can be prepared, and we may get a higher yield of EGFR mutation. Recently, one patient I had sent in a similar way, and I got the EGFR positive in that patient. So what are the factors determining the choice of EGFR mutation testing? So the commonest factor would be the availability of tissue. If it's a deep-seated small primary, then it becomes challenging to do a biopsy because of risk of developing pneumothorax, and also bony lesions. We have discussed many times in our meeting here. To do a biopsy from a bony lesion, then to decalcify and get a EGFR mutation becomes that much more difficult in patients with bone-only metastasis. So there is a lot of things which are dependent on the patient, and in such a scenario where doing a biopsy from a deep-seated lesion is difficult, we go for a circulating tumor DNA. I think that there is a subsequent slide. So basically, IHC or FISH is not recommended for EGFR. So PCR-based assay is what we should be doing. I think that is Scorpion-based and RT-PCR. So basically, the tumor content should be around 10% or more to get a proper report. So also this is one scenario where there are many times we come across this scenario where accessing the tumor becomes difficult. In that particular challenging scenario, we make use of this liquid biopsy, and if we are able to get a tumor DNA on that, then we are able to run the EGFR mutation. I have got a report in 1 or 2 such patients as well. The second most common thing we test for after EGFR is the ALK gene. So initially, how it evolved was when we used to test only for EGFR. When ALK and ROS, we started testing for it was after testing for EGFR, and ALK and ROS was a reflex testing. So we would test them only once we got a EGFR negative report. So we used to wait for because they are mutually exclusive. So if you would have a EGFR mutation, we would not generally test for ALK or ROS, and only when we would get a EGFR negative, we would test for ALK or ROS mutation. So ALK is anaplastic lymphoma kinase. It's caused by rearrangement of EML4 and ALK gene. It's a fusion oncogene, and it is found predominantly in adenocarcinoma of the lung, and the prevalence is around 3 to 5% in Indian population. False positivity rate is actually 0.1% with FISH. So, but still we get ALK done by IHC method as it is a very sensitive method of testing for ALK. In terms of RT-PCR, there are a few challenges. Some alteration in the fusion, like there will be some variants which might be missed, and it requires multiplexing. So there's a lot of technical challenges when RT-PCR is performed with ALK. So for now, I think most of us are convinced that we do IHC for ALK as well. Likewise, for another target called ROS1, this is another important mutation which we come across in adenocarcinoma of lung. The incidence is around 3% in our Indian population, and we have a drug which targets ROS1 mutation, crizotinib. So even though FISH is relatively easier to perform, there's a high failure rate associated with the FISH. So there are a few ongoing clinical trials, phase 1, where they're trying testing it with anchored multiplex PCR and trying to tag it with NGS. And also there are, but still for now, ALK and ROS, we are still testing with IHC for our day-to-day clinical practice. So this is the algorithm which all of us are following. We are testing for EGFR, ALK and ROS upfront, EGFR by RT-PCR or NGS, depending on the patient's affordability, and ALK and ROS by FISH. I think most of, with IHC, most of us are doing that, using the coupons from some of the companies, and that is, that is very helpful for our patients. Also for PDL1, I think no talk is complete without discussing PDL1 expression. So I think everyone knows how PDL1 is targeted, and there are so many platforms available like SP263, the DACO22C3, and SP142. So there are certain conditions where we use each of these. In, for example, in triple negative breast cancer, we use the SP142 platform, and for the other solid tumors, we use the DACO platform. So depending on the type of tumor we are dealing with, we ask for a relevant PDL1 testing methodology. So to put things in perspective, by and large, we do EGFR ALK-ROS for almost every patient. The secondary panel would ideally have a BRAF, MET, RET, or HER2 with KRAS. This would be probably on an NGS. So, but for my clinical practice also, I am more or less confined to EGFR ALK-ROS and the odd patient PDL1. So this is the same algorithm put in the same way. So if someone has EGFR positive, we would ideally give TKI plus or minus chemotherapy depending on our center of practice. And for ALK positive, ALK inhibitor, either crizotinib, alectinib, and likewise for ROS1, we would give crizotinib. So it's very the TAT is the one thing which all of us are really worried about. We are as worried as the patient. So ideally, TAT should be around 1 week. Most of the IHC based, we are able to get around a week's time, depending on the working days, probably around 10 days. But PCR takes that much slightly longer time. And one more thing is it's slightly more expensive. So for most of our patients, we prefer IHC for ALK and ROS and PCR for EGFR. So most of the labs should strive to get a shorter TAT, and ideally these things should be performed in-house. We do have an in-house digital droplet PCR for EGFR. Still, it is not standardized. We are working on it. So that is for the liquid biopsy. So I think going forward, most of the hospitals will have in-house facilities for most of these tests. So now coming to from the bedside to bedside, osimertinib as adjuvant therapy. Now from with the ADAURA trial, we know that there is data where we should ideally test for EGFR mutation in early stage lung cancer as well. So this is the data from the ADAURA trial. We can see that there is a significant number of patients harboring EGFR mutation in the stage 1, 2, and 3 setup as well. So it's pertinent that we test for EGFR in the early stage lung cancer as well. This was not the teaching when we were in training. So so now I think we should test for EGFR ALK-ROS even in the upfront in the resected lung cancer as well. So there are so many ongoing trials. I'll not go into details of these. So and also there are a lot of phase 3 trials where they're trying IO in the adjuvant setting. These are the following trials with nivolumab, pembrolizumab, durvalumab, and atezolizumab, and they are looking at. The interesting thing is some of the trials don't even have chemotherapy doublet as the standard backbone. So they are randomizing after resection to IO. So it will be interesting to see what will be the outcome of these studies. But I'm not sure how many of our patients will be able to complete the whole course of 1 year with these drugs. So it will be interesting to know the data though. And there's also a lot of trials happening in the neoadjuvant space where they're trying to look for these mutations and trying to make the unresectable stage 3 adenocarcinomas, NSCLCs with EGFR mutation, trying to make it resectable. So that is very interesting. I think this is far more interesting trial which are happening, and the data which comes out will be very interesting to see. And not just the EGFR ALK-ROS, they're also looking for rarer mutation like NTRK fusion, BRAF, and RET fusion. So the Nautica 1 study hopefully will give some positive data in time to come. So likewise, in the adjuvant setting, IO therapy also looks very promising, where they are trying to combine IO with chemotherapy and then continuing the maintenance with IO alone. This will also be little challenging in our country, but I think the response rates will be very good with IO with chemotherapy doublet, and there are a lot of interesting data awaited from these trials. So to conclude, biomarker testing in non-small cell lung cancer has evolved from single gene to multiplex testing, and more and more meetings will help us understand the study, understand the sample requirements, and also we should have target at least 10% of tumor content in the biopsy to prevent the delay in processing. And we now know that adjuvant osimertinib prolongs DFS in patients with EGFR positive non-small cell lung cancer. And a lot of interesting IO data coming up in this space. So with that, I think I come to an end of my presentation.
Thank you, Vijit, for the wonderful talk. Actually, the last few slides were quite interesting, that neoadjuvant, adjuvant, and all those things. And perhaps lung cancer is the one where maximum developments, newer therapies are tried out, if you see, among all the other cancers. The guidelines keep changing every 2 months. If you say open your NCCN, and if you are not open to NCCN for 6 to 8 months, then a lot of things would have been changed in the guidelines. Okay, fine. Perhaps we'll discuss these things during our panel discussion. So I would like to call upon Dr. Rachan to talk on resected lung cancer, EGFR mutation positives. Rachan, over to you, please.
Thank you, Sanyo. At the outset, I would like to thank AstraZeneca for providing this opportunity. Is my screen visible?
No.
Just a second. No?
So not yet, sir.
Sir,
Is
can you share your slides?
Yeah, please share my slides. I am having some difficulty in sharing.
So can we go ahead, sir? Rachan, sir?
We can't hear. Can you hear me now?
Yes, sir. Your voice is audible for us.
Yeah. So can we go to the first slide?
Hello, Rachan, sir. First slide is there, sir.
Yeah. So today I would like to thank AstraZeneca for providing this opportunity. And our talk is on newer paradigms in the treatment of resected EGFR mutated early stage lung cancer. Next slide, please. So 1 in 3 patients with non-small cell lung cancer present with resectable disease. And as Vijit has told, it is one of the leading causes of death. And more than 85% of all lung cancers are non-small cell lung cancers, with the estimated 30% of the patients presenting with resectable disease at diagnosis, less so in our country. So localized or early stage lung cancer stage 1B and regional or locally advanced stage 2 and stage 3 are deemed resectable. Next slide. Even though early stage lung cancers present undergo resection, majority of them do not have a cure. So by using adjuvant cisplatin based chemotherapy in stage 2 and 3A non-small cell lung cancer, there is a benefit of giving chemotherapy. The OS rate of hazard ratio of 0.89 and DFS also favored adjuvant chemotherapy, the adjuvant cisplatin based chemotherapy. So, but 45% of the patients relapse in stage 1B, and 62% relapse in stage 2, and 76% of the patients relapse in stage 3. So, based on limited number of studies, the prevalence of EGFR mutations appears broadly similar across disease stages. So, the estimate of EGFR mutated lung cancer in Asians is higher than Caucasians. It's about 30 to 40%. Across various stages, it's about 30 to 40%. So, since EGFR targeting prolongs survival in stage 4 disease, so trying them in adjuvant setting probably should show benefit. So that's why the trial was conducted. Next slide. So osimertinib was used as an adjuvant therapy in patients with stage 1B or 3A EGFR mutated non-small lung cancer after complete tumor resection. So ADAURA was a double-blind phase 3 study, and it was stratified based on 1B to 3A patients on EGFR mutation and by race. So, there are two arms, osimertinib arm and placebo arm, and chemotherapy could be used in either of the arms. And coming to inclusion criteria, that is in the next slide. So all adult patients more than 18 years and more than 20 years in Japanese and Taiwanese population, and post-operatively staged 1B and 3A cancers, central confirmation of exon 19 and or L1858R EGFR mutation. Standard post-operative adjuvant chemotherapy up to 4 cycles was allowed, but not mandatory. And MRI and CT scan of the brain was conducted necessary prior to surgery. Exclusion criteria: all patients who have received neoadjuvant therapy, either chemotherapy or radiation, or any TKIs. And if the time interval between surgery and randomization is more than 10 weeks, if no adjuvant chemotherapy is given, or more than 26 weeks, if adjuvant chemotherapy was given. Segmentectomies or wedge resections are not included, and any patient with cardiac QTC prolonging cardiac conditions were not included. And medical history of ILD was not included. So coming to baseline characteristics, both males and females in osimertinib study, females are more overrepresented, and the median age was around 64 years in both the arms. Asians and non-Asians, Asians were more, Asians were more than non-Asians, and brain imaging was done in almost all the patients. And adenocarcinoma, the most common type, and exon 19 deletion was in 55 out of 55, and exon and L858R mutation was 45, and most patients received, about 60% of the patients received chemotherapy in both the arms. Now coming to the osimertinib DFS survival graph, there is significant divergence of the graph. So hazard ratio with osimertinib arm is 0.17. And in the overall population, significant, it was 0.2. More than 90% of the patients were alive at the end of 2 years in osimertinib arm, and about 80% in this placebo group, 85% in the placebo group. Overall population also showed significant divergence of the graph, and hazard ratio is 0.2. So 2-year disease-free survival percentage in 1B, it was 88%, in 2 it is 91% with osimertinib arm, 88% in 3A, whereas as you can see in placebo arm, 2-year disease-free survival rate was only 56% in stage 2, and in 3A it was only 32% of the patients were disease-free in stage 3A. So since 1B is a lower stage disease, 88 and 71, even in 1B, there is a significant difference. Next slide. This is a subgroup analysis of disease recurrence or death according to investigator assessment. So among males, did slightly better. Younger population did, older population did better than younger population. Smokers didn't do as well. Asians did better than non-Asians, and lesser the stage, the better was the outcome. So in stage 1B, 2, and 3A, lesser the stage, better was the outcome. So this is the median overall survival of these patients, and investigation remain blinded to treatment in order to facilitate assessment of OS at maturity. Next slide. Click again. So median overall survival was not reached. So now coming to various other TKIs which were used in this setting, in early adjuvant setting. So erlotinib was used in, there are various studies like SELECT study, RADIANT study, EVAN study, adjuvant BR19 study. Most of the studies showed DFS benefit, but OS benefit was not seen. Next slide. So probably the OS benefit was not seen because most relapses happen in the CNS because erlotinib does not have CNS penetrance. Local and the kind of recurrences also plays a role. Local regional recurrences associated with the longer post-recurrence survival than distant recurrence. And preventing CNS recurrence is an area of unmet need. So CNS is a common site of distant recurrence in the EGFR mutated non-small cell lung cancer receiving EGFR TKIs, first generation TKIs. And in the adjuvant radiant study, 37% of the recurrences in patients with the EGFR mutated NSCLC with the erlotinib had CNS involvement. And osimertinib has been shown to achieve clinically significant exposure in the brain compared with other TKIs, since it has greater blood-brain barrier penetration. In the advanced NSCLC setting, first-line osimertinib demonstrated superior overall survival and a 52% reduction in CNS progression compared with erlotinib or gefitinib. So in the ADAURA trial, what are the types of disease recurrences seen? So 11% of the patients in the osimertinib arm had DFS events versus 46% in the placebo arm. So in the osimertinib arm, the majority of the patients with recurrences had local and regional recurrences only, with only 38% of the patients having metastatic recurrence compared with 61% of the patients in the placebo arm. So most recurrences in osimertinib arm were local regional, and whereas with distance were more common in placebo arm. This is based on the site of recurrence. As you can see, patients with disease recurrence, CNS recurrences were more common in the placebo arm. There are 10% CNS recurrences with only 1% CNS recurrences. So disease recurrence were left 11% versus 46% in placebo arm. And extrathoracic visceral recurrences were also more common in placebo arm. So CNS disease-free events were much less. CNS disease-free events were only 1% in osimertinib arm versus 10% in placebo arm, and most CNS recurrences have a short survival. Now coming to the overall population, and CNS disease-free survival was not reached in osimertinib arm versus 48.2 months. In the 48.2% in months in the placebo arm. 48.2 months in the placebo arm. So coming to safety, in both the arms, any grade adverse events were similar, but serious adverse events leading to discontinuation was 11% in osimertinib arm, and leading to dose reduction were 7% in osimertinib arm, and adverse event possibly causally related. So no deaths were seen in either of the arms, but more adverse events were seen in the osimertinib arm. Coming to most common adverse events were grade 1 and grade 2, and diarrhea was the most common adverse event, and dry skin, pruritus, cough, all EGFR related TKI adverse events were seen, but however it's much less common. QT prolongation was noted in some population. So post-operative chemotherapy use and outcomes from ADAURA, osimertinib has adjuvant therapy for resected EGFR mutated non-small cell lung cancer. Next, adjuvant chemotherapy use was seen in 60% of the population in both the arms, and median number of adjuvant cycles was four cycles, and majority of the patients received platinum-based chemotherapy, with most patients receiving in stage 2 and stage 3A disease, and some patients in stage 1B disease, that is 26% versus 76%. Adjuvant chemotherapy was used more frequently in patients less than 70 years and patients enrolled in Asia, and was not influenced by WHO performance status. Even in the patients who has received adjuvant chemotherapy, osimertinib DFS events were 11%, and median DFS was not reached, and in fact the survival was slightly better in patients who didn't receive adjuvant chemotherapy in osimertinib. DF is in patients with and without adjuvant chemotherapy by disease stage. So with adjuvant chemotherapy and without adjuvant chemotherapy, there is not much difference, but slightly better without adjuvant chemotherapy, and higher the stage, the better the benefit with osimertinib. And in patients Next slide, next slide. So health-related quality of life health survey. So most of these patients had a better quality of life with this in this study. Next slide. And 85% of the patients were compliant in the osimertinib arm, and there are no significant differences. Most of the patients completed the study interval of 3 years. Time to deterioration of physical and mental component during the disease-free period, majority of the patients did not experience a clinically meaningful deterioration of physical or mental component. And for those patients with deterioration, so adjuvant, coming to summarize, adjuvant osimertinib is the first targeted agent in a global trial to show statistically significant and clinically meaningful improvement in DFS in patients with stage 1B, 2, and 3A EGFR mutated non-small cell lung cancer. Overall, there was a 80% reduction in the risk of disease recurrence or death with osimertinib. Osimertinib was placebo. DFS rates were at 2 years were 89% versus 52%. And adjuvant osimertinib demonstrated clinically meaningful improvement in CNS disease-free survival compared to placebo. The safety profile was consistent with the established safety profile of osimertinib, with mild EGFR TKI class effects reported. Median duration of exposure of osimertinib was 22 months in the study. So, to summarize, adjuvant osimertinib will provide a highly effective practice-changing treatment for patients with 1B, 2, and 3A EGFR mutated non-small cell lung cancer after complete tumor resection. Thanks for listening.
Thank you, Rachan, for this excellent talk. The hazard ratios of this adjuvant osimertinib are phenomenal, 0.17, 0.18, and all that. So we will discuss the practical implications, how to incorporate in the panel discussion, probably after 15 minutes. So I would like to call upon Dr. Karthik for his presentation on osimertinib real world data. Over to you, Karthik.
Yeah, thanks, Sanyo. Is my slide visible?
Yeah, visible.
Okay. So at the outset, I would like to thank AstraZeneca for giving me an opportunity to present the real world data. So in this meeting, we have two medical oncologists from Shimoga. I would like to welcome them first and foremost, Dr. Aparna and Dr. Namrata. They are from my native place, and I'm very happy to participate along with them. So coming to introduction, in patients with EGFR mutation, progression-free survival improves after the treatment of EGFR TKI as compared to that with cytotoxic chemotherapy. This was old data. Then osimertinib, an irreversible third-generation EGFR TKI, demonstrated a clinically meaningful improvement in median progression-free survival, 18.9 months versus 10.2 months, more than 8 months benefit. In a phase 3 randomized controlled trial, that is FLORA trial. I will probably quickly go through this trial. And even overall survival was also pretty good. It was 38.6 months versus 31.8 months with the p-value of 0.045. Again, going in favor of osimertinib. So quickly, I'll just go through the FLORA trial. This was in patients with locally advanced or metastatic non-small cell lung cancer. Key inclusion criteria for patients more than 18 years, WHO performance scale 0 to 1. Two specific mutations were included in this study, that is exon 19 deletion and L858R. No prior systemic chemotherapy with EGFR systemic chemotherapy or with the EGFR TKI therapy, and stable CNS metastasis were allowed here. And stratification was based on the mutation status, exon 19 deletion versus L858R. And also it was also based on race, Asians versus non-Asians. So osimertinib was given at a dose of 80 mg per day till the patient had progression, and the competitor was geftinib or erlotinib at the standard dose. And the progression-free survival was the main endpoint. So this was a very important study because here the comparator arm was not chemotherapy arm. It was a standard of care at that moment of time. That was either that is geftinib or erlotinib, and it was compared with osimertinib. And if osimertinib proves increased progression-free survival or overall survival benefit against geftinib or erlotinib in EGFR mutated patients, definitely it becomes the standard of care after this trial. So in this, if you see the baseline characteristics, interesting thing is Asians. The most of the patients were Asians. Predominantly female populations were included. And also, if we see the adenocarcinoma, majority of adenocarcinoma, exon 19 deletion was more. It was around 63% versus 37% of L858R. So progression-free survival was pretty impressive with the hazard ratio of 0.46. It was 18.9 months versus 10.2 months, and it actually gave, if you see the forest plot, almost all the subset actually had benefited with the osimertinib compared to first generation TKIs. If you see the overall survival survival curve also, osimertinib had the overall survival was 38.6 months versus 31.8 months with the comparative EGFR. And the conclusion of FLORA study showed that a statistically significant and clinically meaningful improvement in the overall survival with osimertinib. Median overall survival for the patients in osimertinib arm was extended by 6.8 months. Osimertinib in the is the first EGFR TKI monotherapy to show a statistically significant overall survival benefit versus another EGFR TKI. This is a very important statement. After 3 years, 28% of the patients in osimertinib arm and 9% of the patients in comparator arm remained on first line steady treatment. Again, very impressive. Around 1/3 of the patient remained in the study in the osimertinib arm even after 3 years. Osimertinib presented a favorable and a consistent toxicity profile despite prolonged exposure. So the final overall survival in FLORA reinforces osimertinib as the standard of care for first line treatment of patients with EGFR mutated advanced non-small cell lung cancer. So again, if you come to NCCN guidelines, the EGFR mutation is discovered prior to the first line systemic chemotherapy. Preferred is osimertinib. And if the EGFR mutation is discovered during the first line chemotherapy, either you can interrupt and change over to osimertinib, or you can complete the planned systemic chemotherapy. Then during progression, you can change it over to osimertinib. So coming to the real world data, there are 3 studies which I'm going to speak on. I think I'll not go into the depth of the study. The slides which I thought are interesting, probably I will highlight on those studies. The first study is called Flower study. Why exactly real world data is important? Because in the trial, only 2 to 4% of the patients with the cancer will participate in the trial, and how effectively this can be this can probably it can be practiced in the real world is very important. So how exactly the osimertinib has performed after it has come to the market is the effectiveness of osimertinib which was highlighted in the FLORA study. Is it being does it manifestation in the real world also is very important to basically know. So that's why real world data is very important. And real world data have become useful tools to assess unique insights in routine oncology practices in post marketing settings. So this Flower study had around 126 subjects. Median age was around 68 years. Brain metastasis was present around in 30.2% of the patients. Majority of the patients were stage 4. In that, stage 4B was around 90 patients that accounted for 71.4%. And the inclusion criteria of the Flower study included age more than 18 years, histologically and cytologically confirmed diagnosis of non-small cell lung cancer, presence of 1 or more epidermal growth factor receptor mutation. It did not have only exon 19 deletion or L858R. It also included other mutations which we come across. It was rare mutations were also included between exon 18 to 21. Locally advanced recurrent metastatic disease, stage 3B and 4 according to the 8th edition of TNM classifications were included. Eligible to receive first line treatment with the 3rd generation EGFR TKI osimertinib were included. And patients who received the study drug in clinical trial were excluded. So the primary endpoint here is something called time for treatment discontinuation. So this was very important. I'll come to it why exactly it was important. Time for treatment discontinuation measured from osimertinib start to the discontinuation of the osimertinib due to any other cause. The other primary endpoint was rate of treatment related adverse effects. And the third important primary endpoint was rate of dose reduction and temporary or definitive treatment interruption due to adverse events. Just give me a moment. Yeah, sorry for that. Okay, so treatment for time for treatment discontinuation is very important, because in real world what we see is when the patient is on can you hear me?
Sir, audible, sir.
Yeah, so treatment time for treatment discontinuation is very important. It's a surrogate marker of PFS actually. Why exactly it is important? Because in real world, if there is a oligoproliferation, say there are some 5 to 6 sites of metastasis, and we start the patient on osimertinib, and if we think that there is one place where it has progressed and rest of the places where it has regressed, probably we will continue osimertinib. So we don't basically discontinue with the osimertinib or with the primary treatment, and we continue it. That is how the real world actually, I mean, we practice. Most of the patients, most of the physicians do practice it. It is based on a clinical judgment. So treatment time for treatment discontinuation is one of the very good indicators for real world data. Actually, based on around 12 to 14 meta-analysis, they concluded that TTD is a good modality to basically explore when it comes to real world data. So coming to secondary endpoints, the secondary endpoints was median overall survival, median progression-free survival, overall response rate, disease control rate. Also, there was diagnostic therapeutic pathway where actually during the progression, the patients were tried to there was an attempt to make rebiopsy, and there were attempts to make the find out the resistant mutations because of which there was progression. So coming to primary assessment and effectiveness, patients with the poor performance status, comorbidities, rare EGFR mutations, and active brain metastasis who were actually excluded in the FLORA study were included. This is how we treat the patients in real world. We treat the patients with poor PS comorbidities, rare EGFR mutations. So whenever these kind of patients come, we try to basically put the patients on osimertinib, or so these patients were included. Outcomes were similar to the published data, that's adding to the consistency of osimertinib efficacy. I'll come to it little later. No difference in the PFS, time for treatment discontinuation, and overall survival noted in elderly patients, patients with comorbidities and less common EGFR mutations. So if you see the primary assessment, so the median time for treatment discontinuation was around 25.3 months. It was more than the PFS which was observed in the FLORA study. And if you see the patients with or without symptoms, two important categories where the patient, or two important subset where the osimertinib performed better is those patients without any symptoms at the diagnosis, and the patients with less than 3 metastatic sites. So these were the two places where the osimertinib actually did well. And the PF and the TTD was far better than the patients who had symptoms or who had more than 3 metastatic sites. So patients, as I told, so the patients with symptoms and the patients with less than 3 metastatic sites and the patients with brain metastasis, these were the patients who did not do well, and there was a significant difference in the when they did the multivariate analysis. So coming to how number of CRs, PRs, and stable disease, majority of the patients, there was no CRs, majority of the patient had partial response, 73% had partial response, and around 23% had stable disease. So if you come to the progression-free survival, free survival was far better in those patients without brain metastasis and also those patients without any symptoms. So already spoken. So when the patients progressed, there was around 44 patients had progressive disease. 21 patients underwent biopsy at progression. Tissue biopsy was attempted in 44 patients, and liquid biopsy was attempted in in the rest of the patients. And there was, if you see the resistant mechanism for the for osimertinib, MET amplification, as we all know, was one of the very important factor for resistance to osimertinib. It was found in around 4 patients. MET and EGFR amplification in 1 patient, EGFR amplification in 1 patient, and HER2 amplification in 1 patient. Safety data, it was almost consistent with the FLORA data. But one thing which is, or two main things which came out of this real world data is, one is pneumonitis, which was far more in osimertinib group. This was, it accounted for around 9.5%. 12 patients had ILD or pneumonitis. And the second one is venous thromboembolism. Again, it was found in around 9.5% of the patients on osimertinib. So it was, there were a few instances where osimertinib was associated with pulmonary embolism. This was not seen in this flower study, and the more venous thromboembolism was more common. But this venous thromboembolism was not associated with age, performance status, comorbidities, and tumor load. So there was no difference in the survival outcome, which was observed according to the age, comorbidities, type of EGFR mutation, osimertinib's confirmed effectiveness, and the safety in the real world scenario. So this is one of the studies, that flower study, which clearly showed that the effectiveness of osimertinib, the TTD was more than 21 months. And with this flower study, what I could gather was, we have to look out for this pulmonary toxicity, pneumonitis, and venous thromboembolism, which is probably the two important things which was not highlighted in the FLORA study. So coming to the second real world data, it's called OCFACT study. So in this, inclusion criteria included advanced EGFR non-small cell lung cancer with osimertinib as initial treatment. Patient who, exclusion criteria included patient concurrently using other anti-cancer agents or undergoing thoracic radiotherapy, undergoing post-operative adjuvant chemotherapy, receiving osimertinib as a second-line treatment. Baseline characteristics, you have to just remember that there was many patients with liver metastasis. Also, there were many patients with pleural and pericardial effusion. Here, one more important thing is they did analysis on PD-L1 status also. PD-L1 more than 50%, around 11.9% patients were there. 1 to 49%, around 31% were there, and less than 1%, around 30% of the patients were less than 1%. And the number of patients who are included in this OCFACT study was around 538. It was much bigger than the flower study. So PFS was the primary endpoint. Overall survival, TTF, response rate, safety, and post-treatment, CR, PR, and stable disease were also studied. Overall response rate and disease controls rate was other secondary endpoint. So if you see the PFS, it was around 20.5 months, was almost similar to the FLORA data. Male gender, malignant effusion, liver metastasis, and advanced unresectable cases. These were the patients actually who did not do well. So again, I'll repeat: male gender, malignant effusion, liver metastasis, and advanced unresectable cases did not do well. And again, the patients with who had PD-L1 score of more than 50%, the PFS was 11.1 months, compared to those patients who had less than 1%, the median PFS had not reached. So definitely the patients who were PD-L1 positive did not do that well compared to those patients who did not have PD-L1 positivity. So this again, same thing, the patients with pleural effusion, liver metastasis, advanced stage of the disease, and higher PD-L1 subset did not do well, and male gender was associated with poor prognosis. Here again, in this OCFACT, one of the side effects. Why did the patients discontinue? The majority of the patient discontinued because of disease progression. Other important factor why the patient discontinues was pneumonitis. Around 25.6% had pneumonitis. So always remember, when you are using osimertinib, pneumonitis is one of the major side effects, and we have to be careful about this side effect. So conclusion of this OSIFACT study was overall response rate was around 76.2%. Disease control rate was around 94.1%. And PFS is better with osimertinib than with the conventional EGFR TK, irrespective of the PDL1 status. But definitely the PDL, higher the PDL1, the PFS was lesser in those patients who had PDL1 of more than 50%. TTF was around 19.1 months. The median time for the start of treatment to the onset of adverse effect is around 56 days. This is again one more very important thing to remember. So, when can you expect venous thromboembolism? When can you expect pneumonitis? It is around 2 months time when you can expect pneumonitis. Pneumonitis of all grades occurred in 69 patients, grade 3 or higher in 24 patients, and fatal pneumonitis occurred in around 4 patients. So the conclusion was PFS after first line osimertinib treatment in real world practice was favorable. The discontinuation rate due to adverse effects was around 18.8%, especially pneumonitis requires further investigation. So the third real world data, probably I will I'll just go to the conclusion of this data. Because of the lack of time, I will not take much of this thing. So the study, this is the third real world data. The study provides real world insight into the use of first line osimertinib in the patients with advanced EGFR mutated non-small cell lung cancer based on the first line data cutoff analysis of the US subpopulation. This was this actually the third real world data is actually it is a very well conducted. It's still going on. This was data was presented at the interim analysis, and majority of the data in the interim analysis was from US population. There is also a big Asian cohort which is being analyzed, and a European cohort which is being analyzed, which probably in 2013 the full real world the full analysis of this real world data collection will come out. The interim analysis of this real world time for next treatment and death, and real world time to treatment discontinuation results support the effectiveness of osimertinib in real world population. Long term outcome will be evaluated in the final analysis. This third also basically tells that the progression free survival was much better with the osimertinib arm, and it was around 20 months. So all three data of the real world suggest that it is coinciding with the FLORA data. And a few things which I learned with this real world three data analysis is, one is we need to be worried. We need to know about the pneumonitis and the venous thromboembolism as the side effects of osimertinib. So whenever these patients you put the patients on osimertinib, you need to look out for these symptoms. And third is it is reflecting the FLORA data. So definitely it is a very good drug, and still this confirms that it should be the first line treatment whenever you are getting EGFR positive patients. Thank you very much for patient listening.
Thank you, Karthik, for this nice talk. Actually, we had many things to cover since it was quite an extensive topic. Yeah. So the next will be the most interesting phase of our today's webinar. That's the panel discussion, which will be moderated by our Krishna Prasad sir. So over to you, Krishna Prasad sir, for the panel discussion, which I am also part of.
Thanks, Sanyo. So I think we have got 10 minutes each for each panel. I'm not sure. Let's see how it goes.
Yeah.
So the first panel discussion is on managing early stage lung cancer. So I would invite Dr. Karthik, Dr. Vijit, Dr. Aparna, and Sanyo for this. Dinesh is there? I don't think Dinesh is there.
Yes, sir.
So I think four of you, totally five of us. Sanyo, you decide when to stop. You are the moderator today.
Yeah,
So you
yeah.
let us know when to stop because
Yes,
I
sir.
cannot decide that. So early stage lung cancer patient. Let's take up the 67-year-old gentleman, non-smoker, cough, chest X-ray and CT scan showing this nice lesion in the left upper lobe. And PET CT shows nothing else. There are some small sub-centimeter prevascular lymph nodes. So we'll start with Aparna, madam.
Yes, sir.
Biopsy is come as adenocarcinoma. So what do you do next when you get such a patient?
I'll ask surgical oncology opinion, sir, for resectability. And parallelly, I'll also do EGFR, ALK and ROS, PDL1. And we'll take a surgical opinion.
Fair enough, I think. Sanyo, what about you?
Yes, sir. Yeah, right. I mean, probably a year before, probably we would have just referred to our surgeons for surgery. But then now, of course, we have to do the EGFR and PDL1 testing.
Yeah, I think the question, Vijit, is would you recommend a brain MRI at baseline for such early stage non-small cell lung cancer?
For early stage, maybe not, sir. I would not do a MRI brain.
Okay, so I will not go into this role of pathological or mediastinal staging because I think we leave it to the surgical oncologist. So MRI brain actually is suggested for somebody with stage 2 and above. Stage 1A, it's not suggested. Stage 1B, it is optional. This is according to the NCCN guidelines. So I think it is fair enough not to do the MRI upfront for a very early stage disease. But if it is becoming stage 2 and above, preferable to do an MRI to make sure you're not missing anything there before undertaking a major surgery. So this patient, they did an endoscopic ultrasound, no enlarged mediastinal lymph node, so hence underwent surgery. This is the report PT2N1M0. Karthik, what would you do next for this patient?
Yeah, if EGFR has not been done previously, now we have tissue, so definitely we'll do a EGFR. I know about EGFR because after Rachan's talk, definitely, I mean, it has made a huge difference. So EGFR is a must. Probably I'll also ask about ALK and PDL1.
Okay. Madam, what about you? What would you do? Would you ask all
Yes,
these
sir.
things?
We'll ask for everything because these patients, even though suppose the patient comes ALK positive, we may not give anything now, but they may progress, and we'll have the baseline investigations in hand.
Yeah,
So
fair enough,
we'll get
Karthik.
everything, sir. Yes, sir.
Okay. So, in your practice, Vijit, what are the chances that patients have early stage lung cancer? And if so, what percentage really undergo surgery?
Sir, so in the last few years, only 1 or 2 patients I remember, sir, who have undergone surgery. So that's very, very less. Most of them are stage 3 and above, sir, and they are not fit for surgery. So I would say 10% maybe undergo surgery, or less than 10%.
Okay. Sanyo, what about you? High-end patients in UMC?
Yeah. So I think after in last 4 years, if I can remember right, I have seen 4 patients who have underwent surgery. Yeah, 4 patients, and in that I think one patient was out of that 4. The surgeon operated thinking it is very early cancer, but then there are some large mutational nodes when I did the PET scan. So he had not done the PET scan. So otherwise, yes, there were 3 early lung cancer patients whom I have seen operated, and in that 2 were in last 1 year. Yeah. And in that one was EGFR positive.
Okay. Can I ask you what you did for that patient?
He is on osimertinib.
Oh, excellent.
But then we will discuss that later.
Yeah.
I'll put that question at the end. In fact, I have one question regarding that case. Yeah.
Okay. So, what shall we do is, okay, this patient came as EGFR positive. Karthik, what would you do next? Would you offer existing chemotherapy?
Sir, osimertinib if the patient can afford, but if the patient cannot afford, maybe I think chemotherapy.
osimertinib, or if osimertinib is not affordable, what would you do?
We are not able to hear you.
Can you hear me now? Can you hear me?
Sir, we are not able to hear you.
Can you hear me now?
I think it is very low volume.
It is now?
Yeah, now it's
Yeah,
audible.
better.
Okay, sorry. So if somebody can afford, I agree, osimertinib. If somebody cannot afford, what would you do, Vijit?
Chemotherapy, sir. Adjuvant chemotherapy.
Okay,
Platinum-based doublet, maybe.
fair enough. So the benefit of adjuvant chemotherapy, I think, is clearly seen with LACE. And when they subdivided it, the maximum benefit was in stage 3. So we want to definitely discuss this trial, the Adora trial. This is a famous trial of 2/3. So you can see that many 60s are there. Age is around 64, race is around 64. Females are 64, everything is around 60s. You can see adjuvant chemotherapy also around 60s. Interestingly, 5 patient, I think 5% of them had stage 3 disease, not stage 4. So you can see excellent disease-free survival, which was clearly shown by the previous speaker. And compared to somebody getting gefitinib or erlotinib, this seems to have a significant benefit. So Karthik, if somebody cannot afford osimertinib, would you use a combination of chemotherapy plus gefitinib, or would you use chemotherapy first?
Actually, I was about to tell this because even though the data, strong data is not there, but the TMH data is there in metastatic setting regarding regarding the platinum-based chemotherapy plus doublet chemo plus gefitinib. Maybe I will put them on gefitinib, sir, along with the platinum-based chemotherapy.
Okay.
Sir, we had such
I have
a
one
case.
patient like that. Yeah, I have
Okay.
one patient like that. So who was actually operated, EGFR came positive, and I gave actually 4 cycles of cisplatin-based chemotherapy plus gefitinib for 6 months, 1 year.
Fair enough. Dr. Aparna, go ahead.
Yes, we had one patient in Kidwai, sir. He was stage 2, and we gave pemetrexed carboplatin 4 cycles, followed by gefitinib like maintenance. So I think that
How
also
long?
we can do. Instead of combining chemo and gefitinib, we can even give chemotherapy as an induction and then followed by maintenance gefitinib also. We gave for 2 years gefitinib.
Fair enough. Yeah, I think that's a fair enough call. Sanyo, any criticism of this trial?
Which trial, sir? I mean, Adora or?
Yeah, Adora.
Okay. Right now, I cannot remember anything like that which I can criticize at this point of time. Coming to the question, what you just asked, that extrapolation of that TMS study to the adjuvant is a very interesting thing. But then I've never thought that way till now. I mean, whenever I've used only adjuvant. I mean, in those 2 patients, what I said, I had used the adjuvant chemo only. Did not think of adding gefitinib to that. But then it was an interesting thought process.
Okay. Vijit, any thoughts on what would you do for such a patient? Whether you would use a combination of gefitinib plus chemo or sequentially, or any comments on the Adora trial, the negative comments?
I would say to answer your first question, yeah, I would probably give chemo first and probably gefitinib maintenance later on. Depending if the patient is frail, I wouldn't give all together. So if a patient has undergone surgery, would be obviously fit, but I would probably add gefitinib as a maintenance rather than combining together with the platinum-based doublet. I agree with Dr. Karthik that we have a strong data in the stage 4 setting, but in stage 3, I'm not sure if I'll be combining it, sir. And criticism, I can't think of one right now, sir, about Adora.
Okay. So I will just bring out 1 or 2 criticism of this trial. you can see that brain imaging MRI was done in around 50% of these patients. So is it possible that CT scan, we know is not an optimal agent. It can miss at least 10% of brain metastasis. Is it possible that, osimertinib here was used for metastatic setting rather than for patient as an adjuvant setting? That is one. Second thing is we already knew this DFS benefit with even first generation TKIs. So, it's like gambling. One of the comments was this is a gambler's dream. So, you already know you're going to win it. You know that DFS benefit is going to be there. It's just a matter of how much money you're going to make. It's just a gambler's dream. So that is the other, thought process. So Dr. Aparna, your thoughts on that?
No, sir. I didn't understand how this. How it's gambling. I couldn't understand.
See, I didn't mean like gambling. What I meant was this.
Whatever. Yeah.
Yeah, we already knew that there is a significant DFS benefit when you use gefitinib and erlotinib.
Yes, sir.
So if you use a third generation TKI against placebo, would it not mean that anyway patients are going to benefit? So we already knew that the results are going to be there.
The class effect was already known. Okay, yes, sir. Yeah.
That is one thing. Okay. Second thing is the MRI was not mandatory. Is it possible that it would have been an adjuvant treatment?
They would have done it later, sir. I think they would have done it later. After surgery is over, they would have done MRI. Because if they do it before surgery, they wouldn't have done surgery only, no, sir. Maybe they did it later, before randomization or something like that.
Okay. Vijit,
I don't know. We'll check it, sir.
Yeah. Vijit, your thoughts on that?
Sir, I think there are like very early stages. Like stage 1, like you said, we don't have to image the brain upfront. So, that is kind of fair, no, sir? Like in stage 2 and above, I think we need to, because that's what we are doing in our practice as well. If we are seeing stage 2 and above, I think we are asking for MRI brain upfront. So that part, I think I agree with, sir. And it is probably, like you said, it was they knew that it's a win-win situation and they have gone ahead. So maybe there is something to think about over that.
So the third point which I would like to make is adjuvant chemotherapy was not given in 40%. Of course, I think they later on showed that even patients who have not received adjuvant chemotherapy or received adjuvant chemotherapy benefited. That is yes. But if you have seen the recent FDA comment, they did not grant permission to use a Chinese drug, a Chinese-made monoclonal antibody, a PD-1 inhibitor in the US. They did not grant approval. One of the reasons they said was the trial did not have ethical values because the control arm did not have chemotherapy at all. It was against placebo. So now 40% of these patients did not receive chemotherapy at all. So we already knew that chemotherapy, adjuvant chemotherapy, is an established treatment for these lung cancer patients. So in 40% of the patients who received only placebo, no osimertinib, no adjuvant chemotherapy, how ethical are we in comparing this thing? So because this thing was already known before the trial was out. So your comments on that, Sanyo?
Yeah. So regarding this comment regarding this 40%, I thought, that was okay. Why? Because stage 1B was almost 35%, 30 to 35%. So I feel majority of the patients who had not received chemo were in that 1B. I hope so, logically. Probably because in 1B, more than 4 centimeter, of course, there is a indication to give. Probably some clinician would have not given, because that criteria of giving chemotherapy versus not was dictated by the physician who is looking after the patient, not by the trial. So the 40% not receiving chemo, I suppose majority would have been 1B. That's okay, I suppose. But if at all, if you go into the details of this trial in the supplementary appendix and see how many of the 3A have not received chemo, then that would be a very interesting thing to know. How many of the 3A patients have not received chemo? So that's one thing.
Yeah.
The other thing
point,
is regarding the CT MRI. That I don't think would have made a much difference, like what Vijit said. And the third thing is the DFS thing, what you said. That I thought I could not suddenly remember when you asked me. But then I was thinking this. How come? Even Deftinib, all those are also having only DFS. And after 2 years, if you say that there is no OS benefit, then what? We have been using it. So this point was there in my mind, and definitely that's a valid criticism. But then I probably, since this has got very good effect on the CNS, probably things may be different compared to the first or second generation TK with this in this matter.
Yeah, I think excellent points, Sanya, because these were the criticisms of this trial, and I think you have taken it up point by point. Having seen
Sir,
all
can I make a comment, sir?
Oh yes, Karthik, definitely.
Yeah. Sir, I think AstraZeneca people will be very unhappy because we are actually trying to criticize. The hazard ratio here is, I think, 0.17. So it is much better. I mean, far better than any of the TKs, first or second generation TKs, which was used and which actually gave a DFS benefit. And they did so much of, I think Rachan showed most of the slides, they did so much of what you call subset analysis, stage 1, whether osimertinib benefited or not, in spite of giving chemotherapy. I think stage 1B there was less benefit. 2A and 2 and 3 there were more benefit of adding osimertinib with or without chemotherapy. So there was a clear-cut evidence telling that osimertinib did make a difference in those patients who did take chemotherapy as well as in those patients who did not take chemotherapy. So they tried to basically come out with the answer, and definitely I do agree, if there would have been a subset where the osimertinib, if it had been compared with the standard chemotherapy maybe, and if all of them would have received chemotherapy, then I think yes, this would have been a fantastic trial. But there is a small loophole, but they tried to cover it with a lot of subset analysis, and they tried to tell that osimertinib did make difference with or without chemotherapy in all 3 stages.
Yeah, I think all of you have given very good answers to whatever criticism I had. I think that would make them very happy. So with that, I think I will end this session. We'll give the final
Sir,
thoughts.
one last question
yes,
I
madam,
want to ask you, sir. Yeah, when we have done PET CT scan for staging, do we have to do MRI brain also for any stage? Usually we do staging PET CT, no, sir. So what about MRI brain?
Yeah, so I think I have the pleasure of deflecting that question to Dr. Sanya.
I will answer this. Nice question. The immediate answer what you get from someone would be not required. MRI would not be required. But then if you see theoretically, PET is not a very good modality for brain imaging. Number one. Number two, I'll just give one very practical example of what happened last week. One patient, that was lymphoma, but this PET scan was showing a single lesion in the brain of around some 3 centimeters something. Okay. Then of course we did the radiation. I sent to radiation for RT, and then of course they wanted to do a MRI. They did a MRI. MRI showed multiple small lesions. Okay, so this is just an example of what I said. So of course I think better. You have to do an MRI unless your treatment doesn't change.
Sir, if I can take this question, actually, I learned from my surgical oncology colleagues that whenever you are treating a patient of CA lung with a definitive, with that curative intent, you need to do a MRI. So whenever we refer the patient, even with stage 2, they did MRI, and it is perfectly right because the NCCN clearly tells that patient MRI has to be done whenever you are going with a curative intent. So I think this has to be done in the patients with the early and resectable lung cancer.
Yeah, I think fair enough points here. Dr. Vijit, your final thoughts before I close this.
Sir, yeah, MRI stage 2 and above, sir, as per guidelines. The final thoughts, osimertinib, I think, like Dr. Karthik said, they'll be very unhappy if we don't talk about osimertinib in adjuvant setting in the second scenario. But I think by and large, most of my patients I'm not able to give this drug, sir. So unless AstraZeneca comes down on the cost, it's going to be difficult to give this in adjuvant setting.
Aparna, your final thoughts.
Yeah, I think we should explore osimertinib more and try to see the real world data for ourselves.
Yeah, fair enough. I think with that I will end. I think with the data available, my thoughts are that somebody with early stage lung cancer, he who's been operated, most of them, if they are EGFR positive, would get osimertinib. If it is not feasible due to financial reasons, I think we have two options. One is to give them chemotherapy alone. Other one is to give chemotherapy followed by gefitinib. Giving gefitinib alone might not be that optimal considering everything which is available. So with that, I would close this session and then go to the next one. So the next session is on advanced lung cancer, EGFR positive. So if I can call the faculty, Dr. Anant Pai, Dr. Namrata Udupa, Rachan, Guru, Hemant, and Najib. How many of them are there? Is everybody there? If you can just let me know who's not there.
I'm there, sir.
I am there, sir.
Okay. So let's, okay, Anant, I know you are there. Yes, Anant. So 54-year-old male, a former smoker, only for 20 years, diabetic, suffered pleuritic chest pain, breathlessness, and this is a lesion, left lower lobe lesion with adrenal metastasis. Histology is adenocarcinoma, stage 4. Namrata madam, what would you do for this patient next? CT chest, abdomen, stage 4 CL lung, adenocarcinoma.
Sir,
There
I
are two
will,
direct questions. One, whether you would do a PET CT for such a patient. Second, whether what is the mutation analysis you would do, and what type of platform would you use?
sir, since the patient has already come to us with the CT thorax plus abdomen, I'll ask for an MRI brain only, sir. And I will ask for EGFR all cross mutations. Because histopathology blocks are there with the patient, I will ask for these 3 mutations, sir.
Excellent. Anant, any different thoughts once they reach Manipal?
Sir, I think adding bone scan would be a good thought process, because sometimes we have seen that they may have particular meds. If symptomatic, definitely yes, but otherwise also we have moved totally towards PET CT now for evaluation of a lung mass, because most of them come with the X-ray or a plain CT showing a lung mass. But if CT
So if
chest
this patient had come to you?
bone scan probably, sir. Add a bone scan and MRI brain. And then EGFR, the routine mutation analysis on the blocks.
Rachan, what about you? Same question. You also have a PET machine. What would you do?
CT thorax abdomen done, probably MRI brain and bone scan. But if a very well-to-do patient, he will tell PET and PET is comparable, so PET and baseline. If finances are an issue with most of our patients, then only MRI brain and bone scan.
What about mutation testing? What would you do?
Yeah, I'll send the lung NGS. I would rather send all EGFR, all cross met, KRAS.
Would you do a hotspot NGS or a CGP?
I don't know. Frankly, I don't know.
Guru, what would you do if you are there? Hemant, what about you?
Imaging, the least I would add is a bone scan. Many times in practice, I've not done MRI. But yes, preferable to do a PET. Most often I send EGFR all cross based on PCR and IHC. Tend to add PDL1 wherever feasible, but preferably would like to do an NGS. Hotspot most so. Okay. Reason because slightly earlier reporting, that's it, nothing.
Fair enough. So this patient came as adenocarcinoma, EGFR positive, L858R. So what is your choice, Najib? If Najib is not there, Anant?
At this point of time, most of us are still giving Jeftinib, sir. But if affordable, probably osimertinib.
So, Namrata, this patient has come to you L858R. Basically, the son and daughter is in US and Australia. What would you do?
Sir, because they are affordable. You mean they are affordable? We'll prescribe osimertinib. Otherwise, practically, I'm giving that sort of patient Jeftinib or erlotinib in the first line.
Rachan, same patient with son and daughter in Australia and US, but they are working in grocery shop as helpers. What would you do?
Jeftinib and erlotinib. Jeftinib.
Okay. Hemant, when would you consider a combination of chemotherapy plus TKI?
Moreover, I'm switching to, at least in our setting, wherever feasible, combination of Jeftinib plus chemotherapy. Rather than Jeftinib alone, in case only if its patient is elderly and not probably fit for chemotherapy. The toxicities are fairly well manageable. It's not that difficult as what was expected. But if given a choice of Jeftinib plus chemotherapy versus osimertinib, a single tablet, I would prefer osimertinib.
Okay. Organizers, if Dr. Najib or Guru Prasad comes into the picture, please let me know. Next, Anant, when would you ever use erlotinib and bevacizumab? Anant?
Hello?
Would you ever use erlotinib bevacizumab? If yes, which patient?
I haven't used it yet upfront, sir. Adding bevacizumab, usually I, like I said, I stick to the TKI only. So I've incorporated Bev with chemotherapy, but not with TKIs.
Fair enough. Fair enough. Would we know that the NCCN guidelines?
So can't hear you, sir.
Okay, can you hear me now?
Yes, better.
Sorry. So we all know that osimertinib is now the preferred agent. Is it because of efficacy, safety, quality of life, or overall survival data? Namrata, which one of these is the one reason you would select osimertinib?
Efficacy, sir.
Efficacy, isn't it? So in terms of efficacy, this is, I think, DFS is 18.9 months. And I think the ramucirumab plus erlotinib data is 19.4 months. Does that make you think about ramucirumab plus erlotinib, Namrata?
Ramucirumab plus erlotinib I haven't used so far, sir. But
that is the one with the maximum DFS, isn't it? 19.6.
Yes, sir. But I think the toxicity wise, osimertinib is better than this combination.
Fair enough. Fair enough. So in terms of PFS, osimertinib had an excellent data in terms of PFS of 18.9 months. So depending on the type of mutation, Rachan, so this patient had L858R. Does it bother you, or you treat them the same way as DEL19?
Exon L858R, they do slightly less better than exon 19 mutations. But yeah, I would still use Jeftinib only, because second line, this one dacometinib, afatinib is much more toxic. Osimertinib is...
yeah. Sorry. Osimertinib is less toxic. So if affordable, you would prefer osimertinib, isn't it?
Yes.
And Hemant, there are some, data, especially from the Archer trial, which suggests that dacometinib is a slightly better drug for L858R. What do you think? Is it true?
Yeah, probably yes. Exon 19 deletion tend to do actually much better. In practice, also you have seen that exon 19 deletion. But again, we are trying to dissect the subset analysis. In case somebody is not affordable for osimertinib, my current choice would be trying to kind of push for afatinib at least, because we have that. Archer toxicity, dacometinib is significant, diarrhea is significant. Would not be my preferred choice still.
Fair enough. So toxicity, we all know. We also know that if you look at the overall response rate, it's quite high. maximum with osimertinib with 80%, as well as the duration of response is around 18 months. So overall survival data, we know that Flora showed an excellent overall survival data, 38 months versus 32 months. And Archer overall survival data. Anant, your thoughts on the Archer overall survival data? 27 versus 34 months. It was published in Lancet saying that there is significant benefit.
Yes, sir. So basically, yes, numerically it is definitely there. Quite a good improvement in the overall survival, sir. But the thing is, I think so. Like we all know, toxicity has also an effect. So dacometinib numerically definitely showed a better overall survival benefit, sir.
Rachan, you are the statistician. What did you think about the fact that the Archer study later on they said there is overall survival benefit, but according to the design of hierarchical assessment, only if patient had overall response rate benefit, we should have done the overall survival. What is your thought process on that?
I think I'm not the statistician.
That's what I said, sir. Numerically, it looks better.
Okay. Fine, because you know what has happened is actually it shows overall survival benefit, but they are designed in such a way that they had to first check whether there was PFS benefit, which it did. Then it had shown overall response rate benefit, which it didn't. And even though there was a survival benefit, you just cannot proceed and claim that there is overall survival benefit. And that's what happened when the Canadian authorities rejected it. So while choosing EGFR, would you ever think the risk of developing CNS mets and hence decide your treatment, madam? And this question for you. Do you routinely do MRI brain?
Stage 4, yes, sir. I do routinely MRI.
And how concerned are you when you pick up the prescription to write about brain metastasis?
Sir, osimertinib is better if the patient is affordable. Else, among the other two drugs, I would prefer erlotinib as compared to geftinib.
So you would not consider dacometinib at all, would you?
Dacometinib still have no experience.
Fair enough. Hemant, what about you? Your thoughts on this? Which drug would you use? Would you use osimertinib because it has brain penetration and capacity?
Yes, I think ideally to do brain MRI. No, in my practice, I do not do brain MRI for all patients. Preferred choice would be osimertinib, and in case I do pick up a small metastasis and patient is asymptomatic, I'll let alone be that and proceed with osimertinib feasible.
Fair enough. This is just to say that the Lux Lung 7 trial, subtle brain mets were included, but afatinib did not show overall survival benefit. Archer, all brain mets were excluded, but there are case reports of dacometinib working in the brain. Flora, of course, the stable brain mets were included and it showed good response. CNS response was clearly seen with osimertinib. In terms of PDL1 positivity, what is your thoughts, Hemant? You just mentioned something the other day. Good to share that.
Yes. So I first discussed the patient. So this was a non-smoker, 46-year-old metastatic CA lung. He had large neck nodal mass with CA lung. EGFR all-cross by EGFR by PCR and all-cross by IHC negative. PDL1 95%, and discussed in the group in case any role of, I think, low-dose immunotherapy, everything I had discussed. Then I discussed with one Dr. Nirmal Roth, who's in Mumbai and who has clinical trials for lung cancer and his area of focus lung cancer. He's told me that when somebody has got a really high PDL1, they have a tendency to have a driver mutation, and many times we end up failing in these patients rather than somebody having PDL1 positive of probably 50%, 45%, or probably 60%. When somebody who's got a PDL1 of 95%, better to kind of confirm that there is no driver mutation and then only proceed with IO. So that was about that case. In case of patient who's got PDL1 along with the EGFR positive, definitely I would not consider in those subset. though we have got data for iron power 150. And second thing, what Karthik sir had presented that was very impressive, that somebody who had a PDL1 negative and EGFR positive tend to do really well. That data I did not know, and probably I'll start focusing that way as well.
Yeah, so we all know that, immunotherapy does not do that good a job in patients who are, EGFR positive. Anant, your thoughts? Imagine a patient has got a PDL1 99% and you have done everything, EGFR all cross is negative. You start the patient on on immunotherapy plus chemotherapy, and at the second cycle, this patient's relatives ask for NGS and you get it done. EGFR is now positive. What would you do next? Anant, are you there? Anant? Madam Namrata, you take that question.
Sorry, sir, I did not get your question, sir.
Okay, so this is a man who has got PDL1 95%, EGFR all cross negative by our usual, RT-PCR and IHC, and you have started on chemoimmunotherapy. Relatives obviously are in US, that's why you were able to start chemoimmunotherapy. But after 2 cycles and 3rd cycle, somebody there wants an NGS done, and NGS shows EGFR 95%. You have finished 3 cycles of PEM, Carbo, and Keytruda. What would you do next?
Interim reassessment, sir. Post 3 cycles.
Shows good response. What would you do next?
Then we'll continue with the same, sir.
If you complete 6 cycles, after that, what would you do?
Then I'll reassess him again. If the response is good, we can continue it still, sir.
And you would continue immunotherapy, and on progression, you would change to a TKI.
Yes, sir. Yes, sir. We'll keep it as reserve.
Fair enough. Fair enough. Rachan, what would you do, and any precaution of TKI?
In a patient who chemo is already started, the guidelines suggested to complete chemo and give maintenance this targeted therapy. In this patient, since immunotherapy is most patients who have targeted mutation, driver mutation, they don't respond well to immunotherapy. So this response which we are seeing is probably due to chemotherapy. So complete chemotherapy and followed by targeted therapy. That would be my choice based on
any precautions or any worrying thing you have seen when you give targeted therapy after immunotherapy?
Lung disease. Yeah, that's I've seen some patients who have received some palliative RT also developing ILDs in that field.
Yeah, especially I think with osimertinib, there are case reports of severe pneumonitis. If you have used immuno-oncology drug before, you're supposed to wait for 3 months before you restart or you start patients on TKIs. Regarding safety, we all know this is an extremely safe drug. Quality of life is good. So when would you consider a sequencing approach, Anant? Anant, are you there?
Sir, yeah, I think there's some network problems, sir. Can you hear me now, sir? Hello, sir?
Yeah, I can hear you. When would you consider sequencing treatment?
Yeah, like we know that in some patients, we can at least start with hepatinib like L858R in case osimertinib is.
Definite network issues. Namrata, what about you? In which patients do you think about sequencing?
First line osimertinib is better in any patient with EGFR mutation, sir, upfront to start with. If finance is not an issue.
Excellent.
So after that, on progression, we'll rebiopsy the patient and look for mutations. If they are not, then we will shift the patient if he is having good performance status still to chemotherapy.
Excellent. So you are very, very clear that there is nothing like sequencing. The first thing you would always use the best drug, osimertinib, upfront, right?
Yes, sir.
Excellent.
Because,
Rachan, your thoughts? Sorry, Namrata, go ahead.
14 is an issue, then we will go for the first generation ones.
Fair enough. Rachan, your thoughts? Why would you want to give always osimertinib 5? You can use the geotag study. I think I'll just put this, the geotag study, which was a retrospective analysis and showed a very good response if you give first, second generation TKI and then give osimertinib at progression. What are your thoughts on the geotag?
The problem is it's not always, it's not possible to catch them when they progress. So if they progress, they may not be able to receive subsequent treatment. So catching them frequent follow-ups is very difficult. So I believe in using the best drug upfront rather than using.
Hemant, your thoughts on the geotag?
Yeah, the exclusion criteria, you see that patients who died on first line afatinib excluded, who could not receive second line therapy excluded. That ends up being a major chunk at times. And definitely with the burden of disease that we see our patients present, on progression, they tend to do really bad. So in case I have an option, definitely first line, a single agent, best option will be first.
Excellent. I think here you can see that if you take 10 patients, just like how you have told, 3 of them will die and will not receive second line therapy. Out of the remaining 6, another 3 you cannot catch them, like how Rachan said, you cannot do a tissue biopsy. It's difficult to do. So you may not end up giving osimertinib in nearly 70% of these patients. So I think that's excellent. I think now everybody is happy. All 4 panelists are very clear that osimertinib would be their choice, first choice for patients with metastatic EGFR positive lung cancer, whether it is L858R or whether it is DEL19. So, yes.
Sorry,
yes.
for just
yes,
I want.
Rachan.
What about using dual TKIs, osimertinib plus second generation? Is there any studies like that?
Yeah, I think there were studies. I think there were increased deaths, if I'm sure. Hemant, do you remember anything? Combination?
No, I can't remember I do remember that there has been study, but I don't remember the data. There has been some evidence for using osimertinib and MET inhibitors as a continued therapy. There have been studies of using afatinib with cetuximab for patients to get better response, but they had very high incidence of skin rash and toxicity. But I don't remember specifically 2 TKs. I can't remember the study.
I am not able to remember exactly, but I think there is a study where they showed increased deaths. So, but very interesting question, Rachan. So, Rachan, you get the points. What do you want to say about first line TKI in metastatic EGFR positive lung cancer?
Regular mutations, I would use osimertinib. Uncommon mutations, think about using second line second generation ones. So all patients who can afford osimertinib has to be on innovator osimertinib.
Excellent, excellent closing comments. Anant, your final thoughts?
Sir, like I said, the first line for all patients who can afford osimertinib. Otherwise, routine practice, it's usually has been jeptinib. But I think with the prices coming down, maybe we'll be able to push some more osimertinib.
Excellent. Madam, your final thoughts?
Sir, I agree with others. First line, we have to use the osimertinib. The monthly cost, I think they were quoting 1.2 lakhs today. So still it may not be within the reach of the kind of patients we deal with. If they bring the price further down, first line of choice practical choice would be osimertinib. Otherwise, we have to continue with the jeptinib or erlotinib.
Fair enough. Hemant, your final comments?
Yeah, I agree with everyone. Affordability still becomes a major issue despite the cost reduction. But otherwise, it's an excellent drug in the sense that you have a single drug, oral therapy, single dosing, very good toxicity profile, manageable, and patients tend to do well who are on that. We've seen that. So the drug is excellent. Only this is one drawback, and probably they'll do much better that way. One interesting thing which I was probably going through, that patients also tend to have some leptomeningeal disease, leptomeningeal metastasis, and there is some study for double dosing, 160 mg, a Bloom study or something, which had a better response rates in that. So other than that, I think we end up using the same 80 mg.
So I'll end this session by saying osimertinib is the drug of choice because of 3 reasons. One, the efficacy is very good. Second, tolerability is excellent. And third, CNS penetration in a disease where incidence of CNS mets is high. With that, I hand it over back to the organizers. One last comment is Sanyu had an interesting point to make about one of his patients. If he can do that and then hand it over to Anand for his closing comments.
Yeah. So this is regarding the hematologic toxicity of osimertinib. So I was talking about that adjuvant patient. I mean, after pemetrexed and cisplatin, I suppose. I started on adjuvant osimertinib. So after, I mean, 80 mg dose, after 1.5 to 2 months, he started developing thrombocytopenia and neutropenia. And the platelets went down till 54,000 and WBC of around 2,300 and neutrophils of around 50% around. It will be like grade 2 neutropenia. So grade 2 neutropenia and grade 2 thrombocytopenia, platelets of around 54,000. But then that didn't recover for almost 1.5 month, 1.5 2 months. Because initially I was giving 80 milligram. Then once I got to know that the platelets and neutrophils are, I mean, WBC is coming down. So then I started on, I think, alternate days for, I think, 2 weeks. Then with this alternate day 2 weeks also, the WBC and platelets went down. And then both the relatives and myself were quite apprehensive in continuing the treatment. And then stopped it for almost 2.5 months. And now last week I started with the 40 mg alternate day. Let's see what happens after 2 weeks. Now after waiting for 2.5 months, the platelets came up till 99,000 and WBC came up till 4,000. So has anyone seen such myelosuppression with osimertinib, or is it probably because of post chemo? But then if you see the post chemo, the trial ADORA, in that there was not mention of this side effect, because this was probably less than 10%.
Yeah, if I can take that, I have not seen anybody with pancytopenia, and I never knew that 40 milligram osimertinib is available.
No, only you can score it. It was not available. You have to score it.
Okay, Sanya. Okay,
Yeah.
bye.
I did vitamin B12, folic acid, all those things. Of course, those were a little on the lower side, but they were not quite low. He was, could not find out why it happened in that patient. Yeah.
Sanyo, staying in KMC for so long is hazardous to health. You go back home.
Yeah.
Anand, please, your final comments, and let's all go to sleep.
You do a bone marrow.
Yes, sir. Sir, I think it was an interesting session. We all learned that first line osimertinib in metastatic setting is a wise choice, except for that the cost is an issue. Adjuvant data is really very strong, but like you mentioned, the DFS is very good, but we'll have to look at longer follow-ups. Just a thought process that for patients who we treat with adjuvant osimertinib, in case if they progress on to develop T790M or anything like that, what to do when they eventually progress. But I think it was a learning session for all of us. I thank the organizers for the opportunity.
Hello. So thanks a lot for all the doctors for your valuable time, sir. So thanks once again for your efforts you have put in across, and thanks once again for everyone, sir.